Welcome, and thank you so much for attending this talk. I appreciate the invitation from the University of California Medical Centers to participate in this symposium and to bring you the patient's perspective. I work with von Hippel-Lindau disease, or VHL. As we like to say, we're trying to make VHL stand for Very Happy Life. Slide 2. We are an alliance of families, physicians, and researchers working to improve diagnosis, treatment, and quality of life. We've been doing that for VHL since 1993 and for HLRCC since 2004. That's hereditary leiomyomatosis and renal cell cancer. That's why we call it HLRCC. We're learning to manage our health through gaining accurate information, getting an early diagnosis, and getting the appropriate treatment. Not too much, not too little, and at the right time. Page 3. VHL increases one's risk of hemangioblastomas of the retina, brain, and spinal cord, tumors of the sympathetic nervous system, like pheochromocytomas and paragangliomas, and potentially malignant tumors of the kidney and pancreas, kidney cancer, and pancreatic neuroendocrine tumors. Page 4. HLRCC increases one's risk of kidney cancer as well. It's different cell types in the kidney, and it's a more aggressive kidney cancer. It has been known to metastasize at 1 centimeter long before someone develops symptoms. There are also skin bumps that go with HLRCC, and women with HLRCC get many and very large uterine leiomyomas or fibroids, often necessitating hysterectomies in their 20s. There's also a possible connection with Leydig testicular cancer that's being explored at this point. Slide 5. All management of these conditions begins with regular screenings, and screenings involve MRIs and or CTs. It may also involve some blood tests, sometimes some PET scanning, to find chemicals in the body, especially when you're looking for a pheochromocytoma or if you're checking on kidney clearance to make sure that the contrast dye that you use can be cleared out of the body in a timely manner. Ultrasound is not sufficient to find tumors at these small sizes. And in fact, ultrasound is not even sensitive to the HLRCC tumor tissue, even if it's bigger. So you can have a 3 centimeter HLRCC tumor that the ultrasound will not find. So ultrasound is not going to do the job. Don't let anybody talk you into it. We do need either a CT or an MRI. CT tends to be preferred by the doctors for chest or pancreas and before any abdominal surgery. But other than that, we're trying very hard to use MRIs in preference to CTs to reduce radiation exposure. Before 1980, and I'm on page 6, before 1980, very little imaging was available. And before 1996, there was no DNA testing for these conditions. So even within a family where we knew that this was running in the family, we had no way of measuring who in the family was in fact at risk or how to watch out for new tumors. In addition to that, 20% of the people that we're in touch with are the first in their family ever to have these conditions. So there's a new mutation rate that's really quite high. And when you're the first in your family, you have no family history. You have no clues as to what this condition might be. And getting a diagnosis at all becomes very problematic. If you wait for symptoms with these problems, you're in trouble. Symptoms in the kidney usually mean it's already metastasized. So it's very important to us to find these things earlier, before that metastatic point, when we can do something about it. We can remove the tumor and never have the metastasis to deal with. But at the same time, we're worried about reducing the pain and suffering of these conditions, reducing the risk of infection, reducing the general wear and tear on the individual. Page 7. So this is why we need imaging. You can watch developing tumors. You can use imaging to differentiate between a cyst and a tumor. Cysts don't need surgery. Tumors might. You can find potentially dangerous tumors before they metastasize. You can make a plan of action to remove them before they become dangerous. you can choose the best moment to intervene and stay healthy and avoid metastasis. Or at least that's the plan, and that's what we have been trying to coach patients to do. Page 8. But the costs of imaging are high. Insurance doesn't always approve scans before there are symptoms. Some insurers don't approve scans even after there are symptoms or a diagnosis. Some payers insist on using ultrasound or x-ray first, and that's not going to do anything, so it's actually more cost to them. But the bottom line is that access to scanning is not universal, and we need to work to make it more accessible for the people like those with these kinds of conditions who really need it in order to manage their health. Page 9. Over time, we've learned a number of important lessons. Image quality, for example, is very important to us, especially when you're hunting a kidney tumor that's less than 1 centimeter, or a tumor in the inner ear that may be the size of an apple seed. So having a way of finding those things before they become problematic, before they create symptoms, before they drop your hearing, all that is very important. Do we really need that contrast dye? Sometimes we do, and we need to use it. Sometimes we really don't, and it could be skipped. And I'll tell you a little bit more about some of the concerns we have about contrast dyes. The dosage of radiation adds up over time. We have to use CT judiciously. When we need it, we need it. But when we don't need it, we probably could use an MRI. 3D CT can also be helpful when there are numerous cysts involved. So we like the new technology, we love imaging, and we use it a lot, but please work with us to minimize the impact on the individual. Page 10. CT versus MRI. We try to mix the two in order to reduce radiation exposure. But some doctors feel that it's hard to measure the changes in the tumor when you're swapping back and forth. So the extent to which you can help the physicians with that measurement would be much appreciated. The MRI contrast dye, especially gadolinium, can lead to nephrogenic systemic fibrosis, or NSF, in people who have severe chronic kidney disease. Hello, we have severe chronic kidney disease. Sometimes it is minimal. People may have had 1, 2 partial nephrectomies, so they have some reduction in the size of their kidney function, and that can begin to impact the clearance level. But sometimes people are 1 step from dialysis or on dialysis, and in those cases we need to be particularly watchful, as you know, and there are good guidelines now within the radiology industry to help make sure that everybody is protected from the possible effects of NSF. Current blood work is essential, and you need that to be accomplished before the person shows up in the radiation department. So make sure that that is part of the ordering, that you make it clear to the physicians that they also need to send this person for the current blood work, so that you're sure that their creatinine clearance is adequate, and make sure that their hydration is adequate. So I know some people have been using bicarb. There seem to be a mixture of opinions about whether that's better or not. But in other words, please help the physicians take care of our folks. For brain also, people with reduced kidney function often don't qualify for MRI contrast, in which case, how do we get an accurate measure of a hemangioblastoma or differentiate a cyst and a tumor in the brain, which is also a very, very important thing for us to do. Diffusion-weighted MRI can be helpful for people who are not eligible for contrast. It's also possible sometimes to use a reduced amount of contrast, which will assist in getting a good enough image. So let's take a look at what a patient with VHL or HLRCC goes through. Let's say you're diagnosed when you're 14 years old. You have a CT and or an MRI at least annually for your lifetime. So if this person lives to be 60, and we hope they live even longer than that, that's easily 100 MRIs and or CTs over the next 46 years. And that could be a low estimate. For my son, he's well on his way to 100, and he's only 41 years old. In some research protocols, or to monitor a tumor, there may be periods when the patient may undergo CTs every 3 to 6 months, and that's just that one organ. So when you're dealing with 6 different organ systems, the CTs and MRIs add up pretty fast. Now, don't get me wrong, we value imaging, and I'm on page 13. Imaging is making it possible for us to manage these tumors at all. Well, we're not going to give up on CTs or MRIs. At the same time, we are worried about a number of things, and we hope that you can help us with them. Cumulative lifetime radiation exposure is at the top of the list. Complications if kidney function is reduced. The nephrotoxicity of the CT contrast is of concern, and NSF, of course, is very much of concern. So even though that has been significantly reduced, we still need to be watchful and follow those guidelines. Believe it or not, we are your white mice. We know that we're using imaging like few patients do. We use imaging in a way that the contrast dyes were never tested for. We know we're stretching the envelope, and we have no choice. So without imaging, our diseases are not manageable. So we need your help, and we know that the industry is making strides, and we do hope that they will continue. I went to a conference on imaging just about a year and a half ago. I'm on page 15 here. And these are some of my observations from going to that symposium on imaging. The amount of radiation the patient is exposed to seems to be a function of the machine, the operator, the organ under study, the density of the bone on the path to the organ, and the amount of adipose tissue on the path to the organ, which can be measured by body mass index. Page 16. The newest machines are not always available because of the cost, because of the time lag for bringing them into the hospital, because of the time lag on FDA approval, and the purchase, install, train time. The sets of controls on these machines seem to be extremely elegant and allow for all possible combinations. But the problem is that not all operators know how to twiddle the knobs in the right ways at the right times. It oftentimes takes a radiation physicist to understand how to make all those calculations and adjustments. The variability of the controls amongst vendors, and even amongst products from a single vendor, is pretty amazing. In many countries, you have one chosen vendor, like in Germany, it's Siemens. But in the United States, we have 6 different manufacturers who are selling devices to your departments. And that means that there may be machines from multiple vendors, and certainly machines of multiple ages in the same department. Not all hospitals have a physicist on staff. Page 17. The operator may not be a full-time person, and on-staff full-time operators are usually trained, but what about the guy who fills in on the weekends? Staff turnover requires a constant training and retraining, which adds expense for you. And with every new machine, there's new training, new machine-specific protocols. It's very important to have protocols for your machines so that operators with varying levels of training are not making decisions on the job without guidance. Page 18. Protocols are absolutely essential. Hopefully the machines are eventually going to standardize things and have more sort of automatic modes. You ought to be able to enter the organ I'm studying, the body mass index, the age of the patient, and the machine then should be able to calculate the optimal dosage. That's not difficult science. That's a table that is actually pretty easy to invoke. Meanwhile, we need protocols for every model of the machine, every organ to be studied, and sometimes for each medical question that we're trying to get an answer to. Are we looking for a 1 centimeter tumor in the kidney, for example? Are we looking for a 2 millimeter tumor in the inner ear? Both of these require very special kinds of exams that are not the norm. So we need to know what we're trying to figure out. Here was an example error message that was posted by one of the vendors at the conference. Proceeding with your plan would deliver too much radiation. Either turn up the thingamajig or turn down the whoosy-whatses. It's like, I mean, those aren't the words he used, but it might as well have been, because I had no idea what he was saying. What does that do to the image quality? There are just too many knobs to twiddle and too much knowledge required to twiddle them optimally. I can't help thinking of the old kind of video projector that you had to tune the different colors, and people would muck with them too much and get it just hopelessly out of whack. And so they started mounting them on the ceiling. And I remember I came into a conference room one day, and there was a guy standing on a chair twiddling the knobs on the bloody thing and getting it hopelessly out of whack. Page 20. Patients are often asked to repeat scans. Why? Because the second physician doesn't have the viewer or doesn't think the scan was sufficiently clear. It actually takes less time from the physician's perspective to repeat the scan than to get the first scan from some other hospital. So we definitely need to worry about clarity of picture, and we need to worry about accessibility of those scans across hospitals, across geographies, and from one hospital to the next. Believe me, I live in Boston, where not all hospitals talk to each other. So if radiation therapy is administered, how does that add up with the imaging exposure? If someone is sent for radiation therapy and they've already had 40 scans, what's the additive way of looking at the lifetime exposure there? Tricky question, and we're getting more and more radiation treatment options. We need easier storage and sharing of images. Page 21. And I know that there's industry work going on to make this happen, but please understand from a patient's perspective why this is critically important, as well as for your own convenience. Patients want to be able to share their scans with an expert in order to get a second opinion. Knowledge about VHL and HLRCC is pretty thin on the ground, and so if you're facing a particularly tricky surgery, you want some input from the best guys in the world who know about your condition. So sending those scans becomes very important. I've gotten MRIs from Central Africa asking for a second opinion on a scan. And obviously what he sent me via email is not going to pull the trick. But we get requests for second opinions all the time from other parts of the world. Patients want to be able to store their scans. Picture somebody who was diagnosed at 14 and is here today. He's got some old scans that are pretty big and bulky and, have silver in them and may well have been recycled. So how does a patient keep their own longitudinal history except by getting copies and putting them in the closet? I still have some of my son's scans in the closet. But these days when it's digital, it's easier to do if the things are set up for sharing. And there is an effort, I know, going on in the industry to make that happen. The challenge of multiple hospitals, multiple file formats, the sizes of these files, and what to do with pre-digital scans is pretty daunting for most patients. And yet, the lives of Americans are such that we're likely to move from San Francisco to Minnesota to Florida, and we need to be able to carry that history with us in some rational way. Page 22. Some people are more sensitive to radiation than others. The details of the amount of radiation delivered with every scan needs to be stored in the medical record. Otherwise, today it's impossible to go back and add up just how much radiation did that person receive. People with ataxia telangiectasia, for example, are very sensitive to radiation. Should patients perhaps have radiation calculation badges like your employees do? Maybe that's the only way that we can really add up the total radiation that this person is experiencing. Should patients perhaps have radioprotectors like those for people who are getting radiation therapy? Because the radiation exposure of scanning and the radiation exposure of therapies all get added together in this person's body. Page 23. Before we even get to radiology, there is a patient-doctor conversation that goes on that is part and parcel of what you are going to be accomplishing. So what the doctor and the patient need to agree and convey to you in a rational manner is, what are we trying to accomplish here? What kind of scan is going to be best to accomplish this goal? What's it going to cost? Time, money, radiation exposure, contrast, stress, claustrophobia. Believe me, the patient has a lot of considerations about this. Will my insurance pay for it? Can I afford the time away from work? Is there some medical test that will give us equivalent information? And of course, the claustrophobia question is huge. My child breaks into tears at the very thought of another scan. Do I really have to do this to her? So that conversation may be going on, well, is going on with the patient and the doctor before they even get to you. And the extent to which you can give them information that would help to shape that conversation would be much appreciated. Page 24. We also need radiology to help us state the benefit versus the risk in terms that the patient and the ordering physician can understand so that they can make smart decisions about ordering that scan. What is the benefit versus the risk? And ideally in the future, there will be better, beneficial, lower risk ways of doing this. For example, some new ultrasound kind of machine or an MRI-based machine that would be less operator dependent and would see tiny little tumors without radiation, without contrast. But it needs to be something that we can depend on for image quality and for meeting the goal of the quest. Page 25. The bottom line here is that medicine is a team sport, and let's not forget that the patient is an integral member of the team. The patient is the one who's going to pay for it, not only in dollars, but in their time and in their medical benefit and in the radiation exposure that they accumulate over a lifetime. So thank you very much, and I will appreciate everything that you're able to do to improve the current situation. And please feel free to contact me or my colleagues at the VHL Family Alliance and the HLRCC Family Alliance, and we welcome your input and we appreciate all your help. Thank you very much.